Hello. Welcome back to the Mid Didactics. Today's lecture is on the approach to hypokalemia. Let's start by talking about the etiologies. Exogenous mineralocorticoids can mimic aldosterone and cause hypokalemia. High-dose glucocorticoids can stimulate the aldosterone receptors and can cause hypokalemia as well. Diuretics, they work on the sodium potassium 2 chloride channels or carbonic anhydrase inhibitors or like sodium potassium importers. All of these diuretics can cause hypokalemia. Situations where magnesium is low in the body or hypomagnesemia is present due to alcohol, diuretics, or cisplatinum can cause refractory hypokalemia to correction. So if someone has hypomagnesemia with hypokalemia, we need to correct the hypomagnesemia to get a better result when we are correcting the hypokalemia. Drugs that promote transcellular shifts of potassium can also cause hypokalemia, like acute doses of insulin or beta-2 agonists like albuterol, terbutaline. When we are considering some clinical disorders to be the reason of hypokalemia, we can broadly classify them as either associated with hypertension or associated with normotension. So when the hypokalemia is associated with hypertension, it is mostly due to high activity of aldosterone. It can be seen in conditions such as primary hyperaldosteronism, glucocorticoid remediable hyperaldosteronism, where ACTH can stimulate the secretion of aldosterone directly. Renovascular hypertension, where high level of renin causes high level of aldosterone and subsequent hypokalemia. Liddle syndrome, syndrome of apparent mineralocorticoid excess, licorice use, and congenital adrenal hyperplasia are also other causes of hypokalemia associated with hypertension. Now let's come to the etiologies of hypokalemia associated with normotension. Bartter syndrome, which is apparently loop diuretic effects. Gentleman syndrome, which is thiazide diuretic effects. Renal tubular acidosis, autosomal dominant familial hypokalemic periodic paralysis, and thyrotoxic hypokalemic paralysis. Now let's discuss about some clinical manifestations of hypokalemia. ECG abnormalities that are typically seen with hypokalemia are U waves, T wave flattening, and ST depression. There is increased risk of ventricular arrhythmia in patients with ischemic heart disease with hypokalemia. Skeletal muscle weakness is also seen. Ileus, urinary retention, rhabdomyolysis, nephrogenic diabetes insipidus are typical presentation. On initial encounter during history and physical examination, we should be taking a thorough history regarding their medications, but diuretics, nebulization, insulin, or if they take any licorice. We have to obtain family history because many causes of hypokalemia are autosomal dominant or autosomal recessive conditions. That can give us a clue. And we have to also look at hypertension during our physical examination. If hypokalemia is present, check if it is possible to stop the offending medications or the offending agents. Consider lab investigations if no obvious causes are found, like diuretic use or nebulization, etc. And we should also initiate prompt treatment because hypokalemia can cause serious morbidity and mortality in patient population. Sometimes lab investigations are done prior to treatment to get the absolute best results. And with that, let's discuss about the lab investigations that we need to do for hypokalemia. Typical blood tests include potassium level, magnesium level. Renin and aldosterone levels are typically checked in a patient with hypokalemia with hypertension, or if we are suspecting a clinical disorder. Urine tests, we look at urinary potassium and urinary creatinine, and imaging in the appropriate clinical setting. From the lab results, we can look at fractional excretion of potassium, which is normally at 10%. If it is more than 10%, that means kidneys are losing more potassium. So the etiology of the hypokalemia is renal. And if it is less than 10%, it is due to extrarenal losses like vomiting, diarrhea, or insulin use, or beta-2 agonist use. The problem with fractional excretion of potassium is that it is not very reliable in the background of CKD because potassium excretion per nephron is increased in CKD, so fractional excretion of potassium is also increased. And it's also not very reliable if someone is taking very high level of potassium or if someone is taking very low levels of potassium in their diet. If we are not looking at fractional excretion of potassium, or if it is not possible to look at fractional excretion of potassium in the hospital setup. We can look at urinary potassium levels, and if we are looking at urinary potassium level and if it is more than 20 milliequivalent per liter, it indicates renal etiology because kidneys are not conserving the potassium, and if it is less than 20 milliequivalent per liter, it indicates extrarenal etiology. Now let's come to the treatment. So for treatment, few general measures that we need to keep in mind: that we need to supplement potassium, we need to adjust the diet, and if there is some primary condition, we need to treat the underlying primary condition. For potassium supplementation, we prefer oral potassium. The dose should be between 20 to 40 milliequivalent at a time. Typical potassium containing syrups that are available in our pharmacy has 20 milliequivalent in 15 ml, so we can give up to like 30 ml at a time. If we are considering IV correction, we have to have like severe hypokalemia, like less than 3 milliequivalent per liter. Red should not be over 10 milliequivalent per hour peripherally. Recheck potassium level frequently when we are supplementing potassium. It's very important because we do not overcorrect the potassium level every 2 to 3 hours if we are giving IV correction, or we can be a little slow if we are giving oral correction. If there are some underlying clinical disorders, only potassium supplementation is not going to give the best results. So we need to treat the primary disorder. So let's touch upon some of those clinical disorders that are associated with hypokalemia. So in primary hyperaldosteronism, there is high levels of aldosterone coming from adrenal cortex, and it is suppressing the renin secretion, and we treat them usually surgically or with aldosterone antagonists. If there is like adrenal adenoma that is primarily secreting the aldosterone, we go with surgical treatment. If there is bilateral adrenal hyperplasia, we have to go with mineralocorticoid receptor antagonists or aldosterone antagonists, because bilateral adrenalectomy carries its own morbidity, so we do not want that. For glucocorticoid remediable hyperaldosteronism, there is also high aldosterone and low renin, and the pathophysiology behind GRA is ACTH can stimulate the secretion of aldosterone, so we need to suppress the ACTH. And to do that, we need to give the patient dexamethasone, which can reduce the level of ACTH in the blood and subsequently reduce the level of aldosterone. For Bartter and Gitelman syndrome, as we have already discussed, that these disorders mimic loop and thiazide diuretics respectively. So there is always a volume depleted state. The patients are not hypertensive. They have high aldosterone and high renin level. They have hypokalemia, metabolic alkalosis, hypercalciuria in Bartter syndrome, and hypomagnesemia in Gitelman syndrome with hypocalciuria. We have to give them nutritional support and supplementation for a long term, and these conditions are autosomal recessive. For Liddle syndrome, which is an autosomal dominant disorder causing overactivation of epithelial sodium channels or ENaC channels, and that causes sodium retention, hypertension, low aldosterone, low renin, and we treat with ENaC blockers like amiloride and triamterene. Hypokalemic periodic paralysis is an autosomal dominant disorder, and we treat hypokalemic periodic paralysis with low carbohydrate and high potassium diet. The basis of low carbohydrate diet is that high level of carbohydrate load can give rise to high level of insulin in the blood, and that will shift the potassium from the blood to the tissues, and that shift will give rise to hypokalemia, and the patient will have the symptoms of paralysis. For thyrotoxic hypokalemic paralysis, we need to treat the thyrotoxicosis, and that will resolve the hypokalemia and paralysis. So with that, I would like to finish the lecture on hypokalemia, and I'm providing a summary of the whole thing. I know it can be hard to look through the summary in the video format, so if you want the summary chart, just shoot a mail to me. I'll reach back. And I'd really appreciate any feedbacks or criticism that you guys can give, because that would help me to improve my channel. And thank you. I'll see you guys in the next one.